Welcome, everyone, to our continuing series on trauma. Today, we're going to go over penetrating abdominal traumas. So, come on, guys. You know I had to use this at some point. I just think it's fitting, given the fact we're about to talk about, getting stabbed, shot, speared, pricked, punctured, and all around filled with holes. So, let's get into it. So, when we talk about penetrating traumas, it's important to try to figure out what did the penetrating. And yeah, I realize how many times I'm saying the word penetrating, and I'll try to ease up on that. Sorry. So, gunshot wounds, right? We want to try to find out about the ballistics, the type of gun, the size of the bullet, the flight path, if possible. All of these things are important in helping us diagnose injuries and then in turn kind of treating them, right? So there's a big difference in how we approach, a single wound from a .22 caliber pistol shot from 50 yards away, as opposed to a shotgun blast at close range. And yeah, I realize that RPG or rocket propelled grenade and tank are on that list. Understand, I have a military background, and when military talks about ballistics, yeah, those are actual things that we have to deal with, rockets and tanks. So I put them there. Stabbings and piercings. I kind of put these two in a similar category. They can also be called something known as impalements. An impalement is basically when the stabbing or piercing tool is left there. Usually with stabbings, it's a blade, a sharpened blade, but with piercings, we're usually referring to something that's not a blade, like a spear or a pencil, or, I don't know, something like that. Maybe if you're an Olympian, like a javelin, but, I guess that's still kind of a spear, right? Well, anyway, the most important thing for us and anyone who comes into contact with these patients is if the object is still in them, like if the knife's still sticking out of his belly, don't remove it. Pack it and secure it until somebody else can evaluate it. In many patients, the fact that he hasn't bled out yet is probably due to the fact that that blade is pressing up against the wound and tamponading what is going to be an inevitable hemorrhage. So our assessments for penetrating abdominal traumas are similar to really any of our other trauma assessments. We worry about our ABCs. Now, with penetrating trauma, and in some cases like this, we may work with the CABC mnemonic, where the C stands for controlling life-threatening hemorrhage before we establish the airway. So it goes, control hemorrhage, airway, breathing, circulation. This is a quick process. Basically, someone's applying direct pressure while another person's checking the airway. And the fact here is if they bleed out, the airway's not really going to matter. So our abdominal assessments are always the same, guys. It doesn't really change. It's inspection, auscultation, palpation, and percussion. The only thing that's going to change this is, well, if there's a knife somewhere, it might alter how we palpate or percuss. Really kind of, judge your injuries depending on to your assessments. Judge your assessments to your injuries. We want to watch trends. We definitely want to watch that blood pressure. And as always in trauma, first blood pressure, do it manually. Then you can go to your monitors. The more hypotensive these guys are, the more we can assume that they are losing blood somewhere, even if we don't see it pouring out of them. If they're going into shock, then they're probably bleeding, and we need to address that. And always to help us is our wonderful friends from radiology, our x-rays, our focused assessment in sonography and trauma, and our CTs. These tools are always going to give us a better idea of internal bleeding. So we talk about in abdominal traumas, there are some pretty ominous warning signs we want to look for. Cullen's sign is bruising around the umbilicus. It's usually indicative of some sort of intraperitoneal hemorrhage. That can also lead, the Cullen's sign can also point towards pancreatic injuries and in females, injuries of the fallopian tubes. Gray-Turner sign, which actually is what you see right here. With this guy, you see his head is up here and his feet are down here. So his right flank is what we're looking at here. Gray-Turner sign, it's bruising to the flank, usually a sign of some kidney injury. I would guess on this guy's kidneys are probably right around here somewhere. But if you see bleeding here, if you see bruising here, you can assume there's some sort of bleeding and some sort of probably retroperitoneal injury, which needs addressing. And then Kerr's sign, that's the pain that a patient gets in the left shoulder when there's an abdominal injury. And usually it's due to a splenic injury. Now, I know it seems weird to have an injury in your belly causing pain in your shoulder, but it's due to the fact that the splenic injury is kind of irritating the diaphragm and specifically the phrenic nerve, which then radiates pain up to the shoulder. So pain in the shoulder, usually a splenic injury. We also can have a situation called an acute abdomen. Acute abdomen is a sign that the belly is filling with fluid, and the pain is caused by the peritoneal space getting inflamed. These patients have that kind of rigid, distended abdomen, and what is that? That's just fluid building up in the belly. That peritoneal irritation is going to cause them, they're going to have just kind of diffuse tenderness throughout their belly. They're not going to be able to really localize one spot for pain. If you see this, these patients are quickly becoming like immediate OR patients. So what do we do? Well, most likely our guys are bleeding, right? So stop the bleeding. Now, we can take this back to basic first aid, right? We see bleeding from a hole. Get a gloved hand on that hole. Apply direct pressure. Not more complicated than that here. If the injury goes deep enough, there's really only so much your hand is going to do. Direct pressure on like a perforated colon is not really the easiest thing to maintain. We want to do our best to try to figure out how much bleeding has occurred and really where it's coming from. Now, in the ED, locating the exact source of bleeding may not be easy or, even possible, but it may also not be necessary. So we're going to use our tools here, our X-ray, our FAST, our CTs. Our friends from radiology are really going to help us get a picture of what's going on inside. Now, while radiology may not be able to narrow down the location of an injury exactly, we may not be able to identify the exact spot until we can get these guys to the OR, and the surgeon can actually get what's called direct visualization of the injury, meaning he actually opens the person up and sees where the blood is coming from. So you guys know about X-rays and CAT scans, but there's one other diagnostic tool that I want to talk about. It's not used as much these days, but you may see it, and that's called the DPL, or diagnostic peritoneal lavage. I'm not going to write that out because it's a lot of words that I may not spell well. Basically, it involves cutting a hole in the belly and inserting a catheter. Now, what you get is, well, if they're bleeding, you're going to get fluid draining out, and that kind of helps us determine the severity of the bleeding. If there's a big rush of blood, we know we got a problem. If you don't get anything coming out, we will actually instill normal saline. We'll flood the belly with normal saline and then drain that. And what we're looking for is color. Do we see red coming out of the belly? Do we see green or brown, which is going to, lean us towards gastric contents that are spilling into the belly? Diagnostically, it was a good tool, but these days, the FAST has really replaced that. I mean, what sounds better? Dripping blood-tinged normal saline all over an ED floor, or just taking a quick picture of the guy's belly right at the bedside? Exactly. And it's found that really these days, the results of the FAST exams have proven to be just as diagnostically sound, if not better than the DPL. So while it is a diagnostically sound tool, there's the better option, and that's the FAST exam these days. So you may not, in your career, guys, you may never even see a DPL. So once we know there's bleeding, well, we got to fix the bleeding, right? If our guy's losing blood, we have to give him a lot. And this is where the MTP, or massive transfusion protocols, come into play. Now, understand, these are facility specific. Right, facility specific. So while the concept of may be the same, basically getting a lot of blood to the bedside very quickly, your facility may call it something different, so just check that. There may be some basic procedures in the ED, like some packing and maybe some ligations, adding sutures that the surgeons can do in the ER, but really for definitive treatment, these guys are going to the OR. As always, when we're talking about any sort of trauma, we got to know our anatomy, guys. You got to know what could be injured, what concurrent injuries can occur. You got to know your anatomy. Obviously, with the possibility of blood and gastric contents and all kinds of stuff leaking into the belly, into the chest cavity, our fluid and electrolyte balance is extremely important. And I think it goes without saying that any time that you pierce the skin and start cutting open organs, you're going to have issues with tissue and skin integrity. A few key points: mechanism of injury. Plain and simple, we want to know what happened, and we want to know what it happened with. What were they hit with, right? What were they stabbed with or shot with? We spoke about some specific warning signs. Try to remember them. Cullen, Gray, Turner, Kerr. Not only should you remember what they are, but what they mean. Always use your tools. Radiology is our friend. I love that. Fast exams, CTs. Get them at the bedside. It's going to give us that picture of what's going on inside. Concurrent injuries with any sort of traumas. You want to remember the concurrent injuries. You want to think of the ballistics. Was this a big bullet, a little bullet? Was it a through and through shot? Or is that bullet bouncing around inside our patient? And when it did, what did it hit when it bounced around? These are all things you got to kind of keep in your head. And we always want to avoid that tunnel vision. It's really hard to take your eyes off that 12-inch kitchen knife sticking out of the guy's belly, but maybe we check to see if he's breathing before we get into that, right? So, as always, thanks again for joining me, guys. If you have any questions, just hit us up on nrsng.com. And as always, happy nursing.